Welcome to Washington Hospital Today, dedicated to informing residents about healthcare topics and issues. Through programs featuring community forums and free health and wellness classes, our goal is to empower community members with the information needed to make informed health decisions. Washington Hospital has been providing healthcare to the residents of the Washington Township Healthcare District for the past 60 years. Today's presenters are Dr. Dianne Martin, infectious disease specialist, Dr. Bogdan Eftimie, hematologist-oncologist, and Dr. Bruce Lin, medical director of Vascular and Interventional Radiology.
So a couple things I wanted to talk about, mostly in terms of hepatitis B. What is hepatitis B and why should we worry about it? How's it transmitted? What are the most common symptoms? What are laboratory tests that we can use to detect it? What are treatment options and long-term effects? So some of the long-term effects are also going to be brought up by Dr. Eftimie when he talks about hepatitis B in the second half of this talk. So just to kind of familiarize with the liver and what it does, it's one of the largest organs in the body. It does multiple things for us in terms of regulating blood sugar, cholesterol. It breaks down nutrients to make them available to us. It helps your body fight infections. It produces most of the proteins that help regulate blood clotting. It produces bile, which is a component that's needed to digest fats and absorb vitamins, and it produces proteins. So this is a very, very important organ that we can't afford to have damaged. So hepatitis B is a viral infection of the liver. About 2 million people in the United States have hepatitis B, and 2 out of 3 are not aware that they are even infected. 1 in 4 are infected with a life-threatening variety of hepatitis B, and we'll talk about that more. So one of the reasons that people are not as aware that they have hepatitis B is that the hepatitis B vaccine was not routinely given in the United States until the early 90s. So those of us born before that were not routinely vaccinated for it. Also, the majority of patients that have hepatitis B come from areas that have high prevalence, and most of that is in our Pacific Rim countries. So China, Thailand, Vietnam, the Philippines have a very, very high rates of hepatitis B. Sometimes upwards in certain communities, 90% of children born are infected with hepatitis B in those communities. And when those families immigrate or bring families into the United States, visiting or otherwise, there's high rates of hepatitis B. The other thing is we're not always aware of what hepatitis B is and why we should be concerned about it. And another reason we're having this lecture tonight, I'm glad that you guys came out for it. So just to back up a little bit, we're talking primarily tonight about hepatitis B, but there are 5 different types of hepatitis. I'm just going to walk through that just so you know a little bit more about the hepatitis and why we're only talking about the hepatitis B. Because if we were going to talk about all of them, you guys would be here till tomorrow. So hepatitis, each one of these are very different viruses. There's a lot of overlap, but they're very unique. So the type A is transmitted by contaminated water. It's not as serious as some of the other hepatitis. Most people get over it very shortly and have lifelong immunity. So this one never causes somebody to die from this illness. They get sick, some may be hospitalized, some people may just have a very flu-like illness, and that's all there is. And there's actually no drug treatment for the hepatitis A. Hepatitis B is what we're talking about, which is transmitted by blood and body fluids. It can cause chronic infections and liver cancer, which is Dr. Eftimie's second half of this talk. There is a vaccine available for prevention for both A and for B. There are drug treatments available, but there is no cure for hepatitis B. Hepatitis C is transmitted similarly in terms of blood and body fluids. Most people who have hepatitis B will get better naturally. Most people who get hepatitis C will not get better. They carry it lifelong. There's no vaccine for C. There are vaccines for A, vaccines for B, but not for C. Hepatitis C is curable by certain medications, but again, people have to know that they have it and get tested for it so they can be aware of it. Hepatitis D is one that's kind of a co-infector with B, so you see those two going together. And again, transmitted by blood and body fluids. There is vaccine available in terms of vaccine for B, because if you prevent B, you won't get D. But there's no other treatment or cure for D. Type E is much more rare in that we don't pick up on it, although it is fairly common in certain areas. It's transmitted by contact with blood or contaminated water. It's not usually considered chronic. It's usually very short-lived in people who get it. There's no vaccine and no treatment for it. So how is hepatitis B spread? It's by contact with blood or body fluids, which can include sexual activity, needle sticks, such as might happen in the doctor's office, the clinic, hospitals, but also from people who share IV drugs and share their equipment for doing IV injections. It's also transmitted from the mom to the baby during pregnancy or at the time of delivery. So if the mom is infected with hepatitis B, then it's transmitted to the baby during the pregnancy. And that's why we see so many people infected with hepatitis B in the Pacific Rim countries, because the moms are not aware that they have it, there's not treatment for it, very little in terms of detection for it, and then it's transmitted on to the baby. Unfortunately, babies or infants who get hepatitis B early on in life, they're much more likely to become chronic carriers, whereas people who get infected later on in life as adults tend not to be carriers. So hepatitis B is not spread by hugging, shaking hands. It's not by sharing cups or utensils. It's not by sneezing or coughing, and it's not by breastfeeding. Symptoms of hepatitis B can start within the 4 to 6 weeks after exposure, and some people may know when they've been exposed, some people may not be aware that they've been exposed. Most common what we see is what we call jaundice, where the white part of the eye becomes a very intense yellow. You can also have yellowing of the skin. You look at the hands of somebody who has hepatitis B and gets jaundice, they're very yellow compared to a normal pink color that we have. Many of them can get abdominal pain, such as flu-like symptoms, nausea, vomiting, can lose weight. And we also see a change in the color of the stool and the urine. And this is primarily because what causes the jaundice is the bilirubin, which is made by the liver. That level rises very high. So that's what causes the jaundice, or the yellow color in the hands, the skin, and the whites of the eyes. And that's what also changes the color of the stool. So most stools are sort of a dark brown. This can get to a very light brown or even a clay color. And the urine can also go from sometimes a very dark, maybe tea color, down to a light yellow or pale brown color. Not everybody who is infected will show any of these symptoms or any symptoms at all. So that's one thing about trying to detect an infection for hepatitis B. The person may not be aware that they've been infected, and they may not have any symptoms of it. So some people can get infected with hepatitis B and resolve the infection within a few weeks to months, and other people become lifelong carriers. So the way that we test for this is blood tests, this is a little bit probably detailed and maybe more information than you want or need to know, but just so that you're aware there are blood tests available. So should you be worried or concerned about it, either yourself or a family member, you can go to your physician or a clinic and ask to be tested for it. So one of the tests we do is for surface antigen. An antigen refers to the body's making a response to a protein particle in the system. So the antigen for this is the hepatitis B virus. So what we're looking for is reactions from the body's immune system to this hepatitis B virus, and it causes an antigen in the system. Most of the times that antigen will rise very high after infection, then start to slowly go away. And in people who have the infection and then clear the infection, the antigen level will resolve, it will go away. So early on in the infection, you can find that in the blood test. As the person gets better, an infection goes away, infection clears, the antigen also clears. Conversely, someone who gets the infection and the infection stays, in other words, becomes chronic, the antigen persists. And that's one of the tests that we use for checking to see if someone has hepatitis B. The second thing that the body does is to make an antibody. And an antibody is much like what we see with a flu shot. You get the virus of the flu shot that's killed, your body makes an antibody that then stays within the body system forever. So even though this might not be the best year for this particular influenza antibody, it might come up later and later and later, which is what we saw a lot of times. About 4 or 5 years ago, we saw a group of children that had gone to Mexico and got an unusual strain of the H1N1 virus, and they became very ill, whereas the older, the grandparents didn't get sick. They'd already seen this virus in terms of antibodies that were in the influenza vaccine from many years ago. So this antibody indicates lifelong immunity. So the body has seen the virus, has created an antigen, the antigen clears, then makes an antibody, which then provides you lifelong immunity. The same thing with a person who becomes chronically infected. They don't have the antibody, they only have the antigen. There's another one called a core antibody, which is usually present during an active infection and will also go away. The E antigen is one that conveys a lot of importance that we look for, because people who have the surface antigen and then have the E antigen have a very high level of virus activity. So that we know that that virus is very active within that person if they have the surface antigen and the E antigen. They're also highly contagious. So you may think that a small amount of blood from a cut or an injection needle from someone else may be very small, but if that person happen to have the E antigen, then the virus is very active within that person, very active within the blood that's transmitted to the person who then gets the IV injection, either from sharing needles, or we also see sometimes transfusions, but this day and age, this is not a common way of seeing transmission of this virus, because the blood banks are so very, very careful with screening for all the types of hepatitis, including the E antigen and the core antibody. So very rarely do we ever see any transfusion infected related activity, AIDS, hepatitis, malaria, many different things. The transfusions now are as safe as they will ever be. The other things that we look for people that have hepatitis or might be concerned about hepatitis is to look for liver function tests. So the proteins that the body is making, that liver makes that helps the body, those are ones that we're looking at, because they can be quite elevated when the virus is active and then infecting the liver. So the liver gets very inflamed and starts making more and more of these protein levels in the blood. Usually once the body has cleared the infection and the infection goes, the body becomes cured, these levels go back down to normal. In someone whom the virus stays active, in other words, they have that antigen but not the antibody, most of the times those proteins from the liver will still remain somewhat elevated. The other thing we sometimes do is an ultrasound, a sonar test. So much like when the ladies are pregnant and we're doing ultrasounds to see the baby, we can do an ultrasound on liver. So what we're looking for is to see if the liver's inflamed or enlarged or might have some spots on it which might indicate cancer. So this is a very good way of looking for other information to help you figure out if a person has hepatitis, what stage they might be in. Rarely do we end up doing liver biopsies, but this is another option for testing to try to see what's going on. If we're not clear on what's going on within the liver, it looks inflamed, the liver tests are a little bit high. Sometimes if we're also worried about possible liver cancer, we'll do a liver biopsy. And that's something Dr. Eftimie is going to talk about a little bit more. So, okay, now I think I might have hepatitis, I've done my liver tests, what do I do next? So one of the things we look for is acute infection. And acute infection is where the body gets infected, body's fighting off the hepatitis infection. What can we do? Most of the times for acute infection, we see nausea, the vomiting, fever. We just treat symptomatically. Most people that get the hepatitis B, especially if we get them in our 40s and 50s, so not at the one end of the spectrum where you're in your 80s you get it, or the other end of the spectrum where you're seeing a newborn that gets it. So middle-aged ones, most of those people will fight out the virus and then become immune and have lifelong immunity. By definition, someone who has the infection, that antigen that we talked about, and no antibody that has carried that for more than 6 months, we consider them chronic. And this is the area where we want to find that person to try to see what we can do to help get rid of the virus if at all possible. So most of the times we see that in men. We see that in people who have alcohol use. We see it where there's co-infection with hepatitis C and D. Many of them go on to be chronic carriers. So treatments for chronic hepatitis involve 2 different kinds of medications. One is an antiviral medication, which helps the liver fight off the infection, and the antivirals can also reduce the complications of the infection, which includes liver damage, cirrhosis, and cancer that Dr. Eftimie is going to talk about later. So there are 2 types of antiviral medication. One is an oral one, and the other one is an injectable one. The injectable one is one that came along earlier, so that's been around for probably maybe about 11, 12 years. That one is very difficult to take because the injections are once a week and has tremendous side effects. They feel achy, nauseated, headache, can't eat, weight loss. It's a very, very traumatic medication, but it does provide cure for most patients. So we sometimes use it with oral medications as well. We also look for it in patients that have liver inflammation or cirrhosis. If a patient does get a liver transplant because they've had hepatitis and get it again, then we also bring in the interferon to treat for that. But like I said, it has significant side effects. The other oral medications, there's a Baraclude, and the first one Vired, and the other one Famility, which is a modified of the Vired, tenofovir, which has less kidney side effects. These are very effective, but they're not cure. So we can put the person into remission. So the virus is basically not detectable, but still there, because they've never made the antibodies, they still have the antigen, the virus is still there, but with these 2 medications, we can put the virus into like a dormant, quiescent, sleeping state. It's still there, but not cured. The other really high risk factor from this, if someone is taking one of these 2 medications and sees their numbers better, and then they said, I don't need this, that's like taking the top off a pressure cooker. That virus will come racing back and almost always fatal. So once we put it into remission, we're very careful to tell the person, this is lifelong, you have to take it indefinitely. Now, could there be a cure coming along later, the next 5 to 10 years? Maybe, but at this time, in this day and age, the reasoning behind it is to keep the virus quiescent, keep the liver damage down, prevent the liver cancer, and the person usually lives a pretty normal life. So if you have hepatitis B, we want people to limit the amount of Tylenol. This is processed by the liver, so Tylenol should be used very sparingly. We also want to avoid any of the anti-inflammatory agents. So ibuprofen, which is also called Motrin or Advil, naproxen, which is called Aleve, or aspirin. So we want to limit any of those medications. Also, they're processed by the liver. Liver stressed by the infection, we don't want to make it any worse. We also encourage people not to use herbal medications. Now, are there herbal medicines that probably are safe? Maybe, but the problem is most of these have not been well studied. We don't understand them enough in terms of someone who has liver damage or liver infections from hepatitis B, so pretty much tell people not to take the herbal medications. So if you're infected with hepatitis B, in other words, you have the antigen and not the antibody, whether you're on medication or not, we encourage people to talk to their sexual partners to let them know ahead of time, to make sure that they fully understand the commitment that they're making to that level of relationship. The other thing that's very protective, obviously, is using condoms. Condoms also prevents against syphilis, gonorrhea, HIV infection, any other sexually transmitted diseases. So I truly think for relationships that are just starting and you're having those conversations, condoms makes a great idea. We also encourage people not to share razors, toothbrushes, or anything that might have blood on it. So again, even a small amount of blood potentially can transmit the virus to an uninfected person. For the same reason, we want any sores or cuts that might be bleeding or oozing also to be covered with bandages, because potentially you can transmit the virus that way to an uninfected person. So if the person's infected, we encourage them not to donate organs, sperm, or other body tissues. There are some studies that are being done to look at people who are infected with this in terms of potential donation of organs, but right now it's not commonly accepted. Might be at some university settings, but it's not commonly accepted. We also encourage people not to share equipment, needles, syringes. If there is a blood spill you might cut your finger or do something where it's bleeding and you have hepatitis, you want to make sure those will get cleaned. Household bleach is perfectly fine. Probably some of the cleaning agents probably not as good, but household bleach is fine for cleaning those things. So in any rag or things that you use for wiping up, you want to make sure you dispose of those properly as well. So bottom line, hepatitis is preventable. Get vaccinated. If you've not been vaccinated, see your family doctor. And hepatitis B is treatable. So if you think you or family member might have hepatitis or you're even concerned about it, it's not unreasonable to get tested. And your physician or a nurse practitioner or a healthcare provider can help you with any of those.
Well, I want to thank Washington Hospital for inviting us to speak over here. And I also want to thank Dr. Dianne Martin and Dr. Bruce Lin, two excellent physicians that have so much information that I learn all the time. I didn't know that hepatitis B can go all the way to R, so I'm looking forward to seeing those strains. I was asked to actually cover the relationship between hepatitis B and cancer. And it is something very important because, especially in this community where we have a lot of people that were not necessarily born in the United States, and they come from most of the countries that Dr. Dianne Martin alluded to, the Pacific Rim countries, as well as the sub-Saharan countries that actually have a high prevalence. So hepatocellular carcinoma, I just want to give you a quick overview, because when we talk about hepatocellular carcinoma, we're really talking about three different cancers. We're talking about cancers that actually start in the liver, and those are actually called the liver cancers. That's what we call them. But there are also two other cancers that can arise in the liver. Those are called cholangiocarcinomas or biliary tumors, biliary carcinomas. We're not going to talk about those today. We're particularly going to talk about hepatocellular carcinomas. It's important to note that actually hepatocellular tumors, so the big umbrella that contains the liver cancers, gallbladder, and biliary cancers, it actually has the highest global incidence. Almost 1 million people a year get diagnosed with one of these three cancers throughout the whole globe. In the United States, it's much less of an issue. Only about 43,000 cases of hepatocellular carcinoma are diagnosed. Just to put that in perspective, breast cancer is the most common cancer in women, and that's about 240,000 patients, 250,000 patients. Lung cancer is the most common cancer overall in the United States. That's about 265,000 cases per year. So clearly 43,000 is a much lower number, but still it's a number that we might be able to avoid, unlike some of the other cancers. This is actually a quick map. The places in red, those are the places with the highest incidence of hepatocellular carcinomas, and you can actually see the Pacific Rim nations. You can see China, Thailand, Vietnam. Over here you can see sub-Saharan Africa going all the way down to Cape Town. You can see parts of South America as well as Central America that actually have a high prevalence. It is the fastest growing cancer death in the United States. So let me explain what this means. It doesn't mean that this is the most common cancer in the United States. That's not what it means. It just means that this type of cancer has seen its fastest growth in incidence in the United States in the last 40 years. So for example, in 1978, only about 1.3 patients per 100,000 people were diagnosed with liver cancer. In 2007, it had jumped threefold to 5 per 100,000 people. It's still much lower incidence than breast, prostate, or lung cancer, but the rapidity of growth tells us that something else is going on. And obviously what is going on is actually the hepatitis B infection. Males, as Dr. Martin alluded to, are more commonly affected than females. So what are the most common risk factors for liver cancer in the United States? And chronic hepatitis C is one of them. It's not the most virulent one, it's actually hepatitis B, but there's so many more patients diagnosed with hepatitis C. Hepatitis B virus, which is what we're talking about today. Excessive alcohol consumption, which turns out to be the most common reason for liver problems in the United States, which can engender an increased risk of hepatitis B. And then this is the one that we think might be contributing to the increased incidence of liver cancers. The non-alcoholic fatty disease, it's associated with obesity. And if you have been watching the trend for the last 3 to 4 decades, at least in Western countries, the obesity incidence has actually gone up and up and up. And there is this entity called the non-alcoholic fatty disease, which is basically an inflammation of the liver that can potentially lead to cirrhosis, which then can lead to to liver cancer formation. So these 4 reasons are the most common reasons in the United States. The one that we're talking about today is actually the hepatitis B. So the hepatitis B virus, as Dr. Martin alluded to, is so common in especially Pacific Rim countries. That is actually over 60% of the hepatocellular cancers that happen in those people happen because of the hepatitis B infection. So just to put it in perspective, there are about 1 million cases of hepatitis B throughout the globe. If we say that 60% of them are caused by hepatitis B, the cancers, then we're looking at maybe about 500,000 cases. If we actually did a screening throughout the globe and tried to figure out who's at risk and actually try to ameliorate that risk by the medications that we have in the Western countries, how many more lives can we actually save? And I say that's actually a lot of lives. And the screening procedures, although they can be a little bit expensive, they're not as expensive compared to other things that we do throughout the world. In the United States, only about 1/4 of the liver cancers that are diagnosed here in this country come because of hepatitis B. 75% of liver cancers in the United States do not come from hepatitis B, but 1/4 of them, they do. And this is what we can concentrate on. And as I said earlier, it's found more commonly in men. Unfortunately, by the time liver cancer is discovered, less than 1/4 of them are surgical candidates. And just to pause here for a second, when we're talking about cancer, with very few exceptions, such as lymphomas or testicular cancers, there's no cure for cancer unless you can do a surgical resection, or more often now, Dr. Bruce Lin will be talking about, you can actually ablate it or take care of it by some other means. Chemotherapy does not cure cancer unless there's some specific cancers, like I said, testicular cancers, lymphomas, some leukemias. But for solid tumors, you need to have a surgical procedure. So that is why the focus on screening for breast, for lung, for prostate, for colon, in this case liver cancer, has always been, can we find out if a cancer happens in its earliest stage so we can get to it by surgery? That's the driving force behind doing screening. Can we get to it by surgery? Because that's the only curative procedure in most solid tumors. But you can see liver cancer, we're not getting to them fast enough. Less than 1/4 are actually surgical candidates. The problem is that by the time you find it, it tends to be multifocal, meaning that instead of one big goomba in the liver, you may have 3 or 4, and they're in different lobes of the liver, so then doing a surgery is not possible. And it has a very long latency period, meaning by the time you actually are the chronic hepatitis B carrier, it can be many, many years, decades, before you can actually have the inception, the genesis of a new cancer forming. And if you're not careful and follow it and try to figure out who those patients are that might get the cancer, you may miss it and you may find out too late when there are symptoms. So, Can the patients be diagnosed earlier? And the answer is yes, they can be diagnosed earlier. And why do we want to diagnose them earlier? Because if you can find the cancer at an earlier stage, they're almost 3 times more likely to be alive 3 years down the road after the diagnosis of cancer than if you found them at a later stage. Even if you find them when they're not quote unquote curable, you can take them out by surgery, but if you find them early enough, you can actually do localized therapies, and Dr. Bruce Lin will talk about it, and those patients have a much longer survival than if you find it out later. So who should have surveillance? And I'll talk about surveillance in just a second. But basically, off the bat, any patient with cirrhosis should have surveillance for hepatocellular carcinoma. Now, there are many reasons for cirrhosis in the United States. The most common one is going to be alcoholic liver disease, but you can also have hepatitis C as well as hepatitis B. With hepatitis C, at least in the last 7 years, I think it was 6 years ago, that the treatment came up that is actually curative for certain strains of hepatitis C. But like Dr. Martin had said, there's no such thing for hepatitis B. We don't have a cure for that. However, once you get cirrhosis, whether you're cured or not, your risk for developing a cancer in the liver is still going to be high. So if you have cirrhosis, you need to have surveillance. If you don't have cirrhosis, but have hepatitis B, okay, if you actually have elevated liver function test, which imply that there's actually an active inflammation of the liver, if you have a family history of liver cancer, if you actually come from the endemic regions in the world where you can actually have an increased risk of hepatitis B, such as sub-Saharan Africa or the Pacific Rim countries, if you're an Asian male over the age of 40 years, okay, and an Asian female over the age of 50 years, these are the groups of patients that will benefit most from doing surveillance. So what is surveillance? It's basically a radiological exam that should be done at a predetermined interval. Usually it's about every 6 months. And this is actually an ultrasound that gets done. So I'm just going to pause here for a second and tell you why did I put sensitivity and specificity over there. And these are words that we throw around because when you do a test to figure out if you have a disease, in this particular case, cancer, you want that test to tell you with 100% certainty if you have the cancer that you do have it, and 100% certainty that if you don't have the cancer, you don't have it. Sensitivity tells you that if you see a mass, if you see a tumor in the liver, you're 100% sure that's liver cancer. And if your liver is entirely normal, then you're 100% sure there's no cancer there. That's specificity. And ideally, this test should always be 100% sensitive, 100% specific, and most importantly, very cheap, right? You want very cheap tests. And probably the most important part is the one that they're easy to administer, meaning that anybody can just walk in and say, I want to be tested for disease X, Y, and Z. Here's my finger. Ouch. Okay, I don't have it. I'm out of here. You want a test like that. An ultrasound, unfortunately, is not a test like that because you have to come in, you have to come to the radiology suite, you have to lie on a table, they actually have to do ultrasound images of your liver, then they have to be interpreted. So the sensitivity is not that high. It's only about 80%. What that tells us is about 20% of the patients that are told you have a mass, you may have liver cancer, they actually may not have it. It's a false positive. And the specificity is higher, which means that if your liver is entirely normal, you only have about a 10% chance being told, well, actually, there is something, we just couldn't see it. But if we apply a blood test in addition to the ultrasound, both the specificity and the sensitivity actually will increase. So as a screening procedure is not the most ideal, right? The sensitivity is not high, specificity is not high, and it's a pain in the rear to actually do it. But for those patients that should have it done, this is going to be a lifesaver. because you're going to figure out if a new cancer is developing so you can get to it to a point where it may still be curable. So the treatment. Treatment of choice, like I said earlier, is surgical resection. If you can actually get it out by surgery, that's what you want to do. If you can't, well, I should say, if you can, great. If you cannot, and the tumor is still localized in the liver, there is no disease outside of the liver, and there is a donor that you can actually have, then a liver transplantation could be done. Not done very often, but that's something that is possible. Then localized therapies would actually come in next, and Dr. Bruce Lin is going to talk about them, so I'm not going to go over them. But unfortunately, if you can't have surgery, you can't have transplantation, and Dr. Lin has done enough of these procedures that he cannot do anymore, then systemic therapy becomes one of the mainstays of treatment. And I have to tell you, they're not that great. It's not like some of the other cancers that we hear about where, the cure rates are very high. This is not curable. Liver cancer, once you start to treat it systemically, it cannot be cured. You can prolong life, you can prolong quality of life, but unfortunately we cannot cure it. Surgery can cure it, transplantation might be able to cure it, but we cannot cure it. So chemotherapy doesn't work very well. That is why about 5-6 years ago there was I was still a fellow, so that was 10 years ago. I do apologize, time goes by too fast. There was actually a medication that had been initially approved for renal cancer, and this study was actually done on about 680 patients. And I don't want you to read the details of this, but this is actually a generalized cell. And normally a cell has certain functions, and these functions go on depending on which buttons you push on the surface of the cell. If you push button A, then a leg comes out and it kicks you. If you push button B, then the whole cell explodes. Realistically, cells actually will die off, it's called apoptosis, depending on which button you push. We have discovered about 20 years ago that there are certain particular buttons that we can push, and we can actually make some cells actually die off. What happens in liver cancer is that certain cells, certain buttons get stuck, if you want to call it. On your keyboard, if you use it for too many years, you never clean it, it actually gets stuck, especially the space bar, and it's very annoying because you have to keep pushing on it to move. These buttons actually get stuck, and sometimes cells get stuck in a certain mode of action. The mode of action may be vascular permeability, so they're very easy for them to get out of the vasculature and go in the surrounding tissue. It may actually be metastasis. They're very easy for them to go travel and implant somewhere else. It may be a button that basically says, don't ever die. So that cell becomes immortal. Well, sorafenib, which is actually a tyrosine kinase inhibitor, was one of these medications that can unstick the buttons, if you want to call it. And it actually blocks all of these buttons, so the cell can actually go through its normal mode and die off. And when they were tried in liver cancer, actually patients did quite well. So for patients who took the medication, basically, they survived almost twice as long than patients who didn't take the medication. This is called progression-free survival. The overall survival was about 30% longer. And now they can even go a little bit longer. But this is still not good enough. An overall survival of 11 months is not something that any of us want to see. So about 4 years ago, the immune therapy that is now all over the news and is being used in a lot of cancers came into being, and it was used in liver cancer. So really quickly, don't want you to get bogged down in the details of this, but immune therapy that we use today essentially is one that takes the brakes off your own immune system. So your immune system has a way of saying, I see that infection and I should go after it, but I really want to be careful that that's what's going on, So I'm not sure I'm going to go for it full bore. I'm only going to go for it partially. That partially is a brake that is on the immune system. And that brake has to be over there, because if your immune system goes full bore ahead, it will start attacking your own body. And that's what happens in rheumatological diseases, such as rheumatoid arthritis, lupus erythematosus. Some of the rashes that you have are actually the immune system running at full bore. So your body has its own natural brake to say, no, don't go so fast. The immune therapy that we use nowadays actually takes the brake off. And it allows your own immune system to actually go full bore after the cancer. And it has been successful in a certain number of cancers. Liver cancer, lung cancer, colon cancer, certain colon cancers, bladder cancer, head and neck cancer, melanoma, renal cancer. So we have used this medication, and one of the trials that actually was originally reported happened a few years ago. It was actually in 2017, and I just wanted to show you here a survival for these patients that received this immune therapy. So the red line up top that stops around in the middle, and the black line in the middle, those are actually the immune therapies. Sorafenib is the promising therapy that I told you it was discovered a few years ago. On the bottom, you can actually see the overall survival in months. So you can actually see the middle of the line, the overall survival is about 21 months. On the left side, on the x-axis, that's the probability that somebody's going to be alive. So what you want a straight line to go across the top, because you want 100% patients to be alive for the longest time, right? As soon as the line goes down, it tells you that some patients do not survive. So the higher the line, the better it is. And you can see that with nivolumab, which is actually one of the immune therapies, the line is much higher than the sorafenib, which is on the bottom. So this is definitely a promising therapy that we have in systemic therapy. In conclusion, the hepatocellular carcinoma incidence is rising. The highest risk patients are people from African and Asian descent. Surveillance can definitely decrease the overall chance of dying from cancer if it's caught early. Surgery and transplantation are curable. Localized therapies can improve the overall survival, and this is the purview of the next speaker, Dr. Bruce Lin. Thank you very much.
First of all, how many people have heard about interventional radiology or know what IR is, interventional radiology? See that? Okay, I got my work cut out for me. So good news is that we have a lot of pictures, so hopefully you don't fall asleep, okay? So today we're going to talk about interventional oncology, which is actually a service line, a separate service line under the interventional radiology umbrella. So IR is basically a specialty that utilizes imaging to do a lot of the procedures, minimally invasive procedures. The goal is that we can avoid surgery, right? So we can do things a little bit less invasively and get you out of the hospital or the angio suite the same day, and the recovery period will be shorter. So interventional oncology developed inside the IR umbrella in the last decade or so, because out of the need to treat all these cancers that had required surgical intervention previously. So, if you look up Wikipedia, this is the definition of interventional oncology, is that we treat and diagnose the cancer and cancer-related problems using targeted, and that's very important, targeted and minimally invasive procedures under imaging guidance. So those are the keywords, and you see that why those are important. And we use these very small tools, and the reason why we're able to do so really is that over the last 2 or 3 decades, the technology developed all these very small micro tools that are just amazing. All these small toys that I get to play with. That's the reason why I went into IR. I get to play with toys, but they're able to really perform some amazing procedures and surgeries that we otherwise can't do. So today we're going to talk about specifically hepatocellular carcinoma and how IO, interventional oncology, treats that. So, a lot of these, you saw this map previously, Dr. Eftimie showed that. So, a lot of these incidences are very high in the developing countries, and so actually some of these procedures were kind of honed and fine-tuned by these countries, like in Asia, in China, Taiwan, Hong Kong, Japan, Korea. It's very prevalent there. So a lot of the data comes from there. So If you look at, the liver, so HBV, the hepatitis B is what we're talking about today, but there are obviously multiple things that can affect that. Basically it causes injury to the liver, which then causes a lot of abnormal liver nodules, right? Which then turns into hypoplastic nodule and then becomes dysplastic. So you might not know what dysplastic means, but that word sounds terrible, right? I mean, it's very scary, dysplastic, and then it turns into the hepatocellular carcinoma that we're talking about, and that's what we're targeting. So if unfortunately the HCC is discovered and it's not resectable, right? So if it's resectable, then you go to surgery, you take care of that, then it's gone. But if unfortunately it's not resectable, then we have a few tools that we can use nowadays to help treat that. And this is called liver-directed therapy because the dominant disease is always in the liver. So, the first one was TACE, the conventional chemoembolization, followed by a drug-eluting beads. This is more precision TACE. And then we have developed the radioembolization, using Y90 spheres, and using that we can sometimes perform a lobectomy, radiation lobectomy, kind of equivalent to a surgical lobectomy or segmentectomy. And sometimes we'll use the same technique to embolize a portal vein so that we can grow the other part of the liver. So that if you have to take out a part of the liver, then the other part can grow so that it'll regenerate and be the substitute liver for the part that you cut off, okay? So, and of course then there's the other arm, which is the ablation technique. So we'll go over some of these in detail. So the first one is TACE. So it stands for TransArterial Chemoembolization. So this word is important. You have to break it down into the chemo and the embolization. Embolization is actually a technique that we've developed for decades, probably as early as the 1930s. And what that means is blocking vessels or tubes with particles or glue or coils or any other devices that we can actually put into that vessel, and we stop the blood flow, okay? So if we combine the chemo with the embolization, then what we're trying to do is that we're delivering the chemo selectively into the artery that feeds that tumor. So by doing so, we're actually increasing the concentration of the chemo in the tumor, right? Because now it goes directly in there instead of systemically with the systemic chemo. And also we're increasing the dwell time by as much as 20, 30 times. So it'll stay in the tumor and not just wash in and wash out. Okay, so that provides a higher efficiency, a higher effectiveness. And then, we can actually, at the same time, block the blood supply to that tumor. So that's important because tumors thrive, or the hepatomas, they thrive on arterial flow. You block, you take away their feeding blood, then they will shrink. It'll die. So in the early days, when we didn't have the technology to do the chemo part, it used to be called a bland embolization. We would just actually cut off the blood supply and that's it. We don't put anything into it. So with the chemoembolization, we're actually incorporating the chemo into that. And we can use a variety of agents. These are just some of the more common ones, cisplatin, doxorubicin, mitomycin. And we usually pair that with a emulsion oil. And it's really thick. In fact, when we mix it, we have to be careful, and it often melts the syringes that we put that into. So we have to go through several syringes. It's that strong. But what that does is it actually allows that chemo to get tagged or get stuck into the tumor for a longer period of time. And afterwards, when we do imaging, it shows up better. So we know that actually went to the tumor itself, okay? So all of this is to accomplish one goal, is to increase the necrosis, which is the cell death of the tumor inside the liver, okay? And so the larger the tumor, it's harder to really achieve that complete necrosis, okay? But if you have smaller ones, then the necrosis can be fairly extensive, and that's our goal, okay? So in order to understand TACE and some of these techniques, we have to kind of understand the liver anatomy, or at least the vascular anatomy a little bit. So if you look at the liver, we have the left and the right lobes, right? And the supply, actually, it's a very unique organ. The reason why we can do this in the liver is because it has dual blood supply. Unlike some of the other organs that we can't do this in, like kidneys, We can do this in the pancreas and the lung. They only have a single blood supply, arterial supply. But liver has an arterial supply that most organs get, and then it has a portal venous supply. Okay, so it's got a dual blood supply system. Now the tumors, they actually require that arterial supply. It's 100% supplied by the arterial supply, but the rest of the liver only needs about 20% arterial supply, and it thrives on the portal venous supply most of the time. So if you just have portal vein, it can still do well. So this is the reason why we can do this kind of procedure in the liver and not kill the normal cells, right? So what we have is the arterial system. The red is the arterial, the hepatic artery goes into the left and the right, and that's important. And then you have the portal vein that goes in there, and eventually everything goes back into the hepatic vein and back into the heart. So when you have cirrhosis, the connection between the hepatic vein and the portal venous supply going to the liver is unhealthy. So therefore, you don't really have the ability to return that blood flow. And so a lot of times with cirrhosis, you also get a lot of back pressure in the portal vein, okay, called portal hypertension. And people get bleeding from the engorgement of veins and things like that, okay? So if you look at this schematically, the arteries are the branches that we actually go into to perform the procedures. We rarely touch the portal veins unless we're trying to take out a part of it in order to grow the other part. We call it hypertrophy, so it can encourage the growth of the other portion of the liver. So, all right, so how do we do this? So the important part is the angiogram, right? So this is the liver, and what we have to do when we do an angiogram is that we enter into the artery by your groin. We use a needle to get in there and start something like a little IV, okay? And we're able to put in a little catheter, this miniaturized catheter, and do an angiogram. This is what it looks like. Okay, this is the aorta, and this is the artery, the iliac artery that comes down to the groin. So we enter here, we go up here, and you see that branch there? That's the hepatic artery that goes into the liver. So that is the branch that we actually navigate into in order to accomplish some of these procedures. And we get a tiny little catheter all the way out to the branch that actually feeds the tumor, or branches that feed the tumor. And that catheter is actually probably about the size of the tip of the pen. If that's small, even smaller sometimes. And this is what a hepatocellular carcinoma looks like on angiogram. You see how hypervascular it is. So if we navigate the catheter in here, we do an angiogram, we squirt dye in there, it lights up because there's a lot of blood flow in it. And it survives on that artery. And this is what we want to take out, okay? Sometimes you get one, sometimes you get multiple, okay? And so this is important because some of them will be in the left arterial supply and some will be on the right arterial supply. You can't do everything in one single session, so you end up doing multiple sessions, but we're able to do so. And in fact, we can come back and repeat the treatment sometimes depending on how well your performance status is, how healthy you are at that point. So I'll show you one example that I did recently. This is the right hepatic artery. You can see that branch going out. And do you see that little blush there? That's a liver cancer right there, okay? And in fact, if you look carefully, there's a second one here, right? So that means that we have to come all the way out here, take this one out, and then also take out the supply to this one. But the problem is that if you look at this, it's got little thready branches coming from all over the place. So what we had to do is, instead of choosing the beads, we have to do a conventional TACE, and we deliver the chemo into this whole lobe, and then we block it with beads. And the end result is this. You see all of these branches have been trimmed and pruned out. It's all blocked. So now there's no arterial flow to this portion of the liver, but it still has the portal venous flow, so it's okay. But the tumors are no longer receiving the arterial flow, and the chemo is stagnant. It's now in the tumor, in the lesion, where we want it to be. It's sitting there, dwelling, releasing, and doing its work. So sometimes we have these smaller tumors, and the volume of the chemo we have to give is so large we just can't get enough into the tumor. So we came up with these beads. They're called Drugeluting Beads, DEPTase. So what they are, they're little compressible particles. They're tiny, and they actually absorb the chemo. So the day of the procedure, we would load this with chemo, we soak it in chemo, it'll absorb it, and then what we do is we do the same thing we would do here, is we would take the catheter up here, we go all the way out here, and then we release the beads directly into the tumor. And the beads will get stuck in the tumor vascular bed and slowly release the chemo, right? And also it accomplishes the second goal, is that the beads themselves will clump up and it'll block the blood flow. And so it doesn't get any more blood flow into the tumor bed, vascular bed itself. So that's a double whammy. It's the kind of a second way to kill the tumor. So this is one example. If you look at this one, that's one big liver cancer, okay, coming off the left lobe. And here's the stomach, and this is the left lobe, and that's the right lobe. This is the second one that was already treated, and so it looks dark. The rest of the liver lights up because we give dye, and this is the aorta. We gave dye because this lights up. So now the liver, it lights up because it's getting the blood flow, the normal part of it. The part that we killed, right, is dark because it does not get blood flow. It's called non-enhancement, okay? And the rest of the liver is enhancing with the dye. So if you look at after 2 sessions of treating this, and you see all these bright parts, right? That's all vascular flow. So it's alive because it's getting all this light, the flow into the tumor. And parts of it, because it's so big, it just doesn't quite get enough blood flow and actually dies. It has necrosis, and that's what necrosis looks like. So after treatment, this is what we want to see. The entire thing is dark, not picking up any blood supply anymore because it's been effectively treated, and this will gradually shrink. So as you can see, this actually is a good example to illustrate the 3 things that we want to see after effective treatment. One is devascularization. Basically, you cut off the blood supply so it shouldn't light up anymore, right? Number 2 is you want to see necrosis. So that's necrosis, all this dark, non-enhancing dead tissue. And then size change, reduction in size. That's the other criteria to measure whether or not the response to therapy was adequate. And you can see this one going down to that, smaller, okay? So there's actually a really good example to show that. So this is another example. You can see that 2 months after the TACE, you can see some of these areas are already dead, and they continue to progress. Okay, they don't show any enhancement. That's about a year out. And unfortunately, this patient got lost to follow-up for about 8 months or so. She came back, and I did a CT, and this is what we see. You can see she was already resected at one point. If you look at the staples here, the left lobe was already resected at one point. So this is a recurrence. And now you can see all these little bright dots. Those are all tumors. Came back with a vengeance and all over the place. So we did an angiogram, and you see this area, you see all these little nodules. That's all tumor, loaded completely, full of tumor. So at this point, there's not much we can do because there's really no good residual hepatic reserve for us to treat. So one of the things that, it's really sometimes difficult to convey to a lot of patients is that this is a war that never ends. You can win a battle at a time, but you have to keep fighting. You just can't relax. So you can feel good, it may look good, your tumor marker may come down, you may feel like, we're there, but it'll come back. So that's really important to sort of, to keep in mind. So does this really help? Well, there are many, many studies, but most of them are kind of medium-sized. They're really not a good large-size study because it's hard to get so many people together doing the same thing. But if you look at one of these studies and the survival rate, at 1 year, 2 year, and 3 years, TACE versus control, you can see there's a significant difference in the survival rate, right? This is for the hepatitis B. Even for the hepatitis C, it's a similar scenario with basically treating the tumor itself, okay? So after decades of really performing TACE and refining TACE, we've discovered that radiation can also be very effective, but not external beam radiation, but internal. So the yttrium-90 particle in particular emits like a short beta radiation that has been studied and to be really effective for this kind of a treatment. So what they did is they loaded these yttrium-90 particles into tiny spheres, just like the other spheres that I showed you. So instead of having chemospheres, now you have radiation spheres. So each one of those particles has a very powerful radiation loaded inside of that. And the same goal we want to accomplish is to deliver these spheres directly into the tumor bed. And we use the same technique. We get it into these little vessels that feed the tumor. But sometimes you have multiple tumors in one lobe. And in that instance, what we would do is we actually release the spheres into the entire lobe. So why is this better than chemoembolization in a way? It tends to be better tolerated. It's the side effects of the chemo, the absence of chemo is often felt, so people may get a little bit fatigued, but they often do not have the side effects of the chemo that's associated with the chemoembolization. And a lot of times, if you have tumor invading into the portal vein, right? We talked about arterial and portal. So what if you have tumor also blocking the portal vein or a clot in the portal vein? So now you're going to go, well, we can't really do anything because if I block the artery, then the portal vein is blocked also, then we're going to have ischemia or death of the normal liver cells. So in that instance, this becomes a good alternative because it can function even in the absence of good portal flow. So basically, it's the same thing. Hepatic artery is, as we discussed, provides 100% blood supply to the tumors and only 20% to normal liver tissue, but the portal vein supplies 80%. So even if the portal vein is blocked, we can still use this because it doesn't block the arterial flow. So we're not using an ischemic effect, so to speak, meaning putting the beads in there and causing blockage and using the chemo effect, but we're actually using the radiation only. So as long as the beads can get into the tumor cells in that area, it can continue to do its work, even if there's presence of arterial blood flow. Okay, so you don't have to have an open portal vein necessarily. And so we got to get into the microvasculature, and it's very dense. You can see that it can be up to 200 times denser than the normal tissue, and that's why this thing works. It's so rich in arterial supply. And these cells are actually very radiosensitive. So, and in fact, sometimes it works in conjunction with the systemic drugs. It actually improves that. So there are studies that are ongoing with like the sorafenib and Y90 study that are together trying to see if that actually improves the survival rate. So it's a little busy slide, but this is kind of the concept that we use for the radioembolization. We try to get the beads directly into the tumor. And so when doing this, we have to be a bit careful because if we just lose one bead outside or on the floor, we have to shut down the entire room for days because it becomes hot. The whole room becomes hot for days. Then we can't do anything in that room. So this is a procedure that is performed in a very controlled fashion. But even then, people worry about the radiation contact. What happens when it sits in there? What if you come in close contact with your pets or your family? Or just outside. So in the beginning, there was a lot of concern. We would isolate the patients for a couple of days, but now we've discovered that actually the penetration is not very deep. It's only in the surrounding tissues that there is no longer a safety concern. Even if you have this procedure, you don't have to be isolated. You can go home and just have your normal routines and not be concerned about direct contact. Okay, because the penetration is only about 2.4 millimeters, but that's sufficient. So we have the number of particles we embed in there, it's in the orders of tens of thousands. Okay, so again, to recap Y90, the idea is to provide a local radiation therapy, okay, it's an internal therapy, not external beam, and healthy tissue remains relatively unaffected. We typically have to treat a couple times especially if you have both left and right lobes involved, then we have to treat them separately. Otherwise, the radiation dosage is too much. So we actually have to calculate very carefully how much radiation we can give you at one time. And it's an outpatient procedure now, so you come in, you get treated, you go home the same day, and you don't have to stay in the hospital. So this is one example. So you can see that very vascular hepatoma there, the white stuff, that's the enhancement that we talked about, right? So when you do an angiogram, that's what it translates into. It's because all these, the microvasculature and the blood flow, the neovascularity, it lights up the tumor, right? This is the rest of the liver, and that's the tumor. So it's a distinct difference in the angiographic appearance of that. And this is why we're able to release all these beads in there into this tumor bed and allow it to kind of go to work, whether it's chemo or radiation. 3 months later, we get another CT, and this is the appearance. This is that area of necrosis, right? There is no more enhancement like the rest of the liver, and it starts to shrink a little bit, okay? This is another example. So that one patient got treated, and about 2 years later, he came back. We do routine CT scans every 3 months to 6 months once you get treated with these liver-directed therapies, because they do come back. And so we find, I don't know if you can see it, there's a little bright area here. You see that? So that's actually a recurrence, okay? And you can kind of see it here. Okay, this is the coronal view looking at it from the front, and this is an axial view, like slicing like a bread loaf. Okay, so two views to look at it. And actually it sits right on top of an area that we had already treated. So we went back, we did another angiogram, did a Y90, and you can actually see the vascularity in that area. I can't see it from here because of the lights, but you can kind of see a ball-like area where there's more vessel. This is a 3D rendition of the angiogram that we performed. So we embolized, we took the catheter all the way out here, did a Y90 here, a very selective one. And 3 months later, this is the response. So that was a previously treated area that already had necrosis. That dot there is that brightness, that was the recurrence, and now it's also necrotic. Okay, so we can be super selective in what we treat with that. So important thing to keep in mind when I see these patients is that, as Dr. Eftimie mentioned, that it's not really a cure. It's not resectable. By the time they present for these kinds of procedures, you're in a non-resectable stage, right? So you're trying to kind of treat this on the long road. And so the performance status, or your activity level and your quality of life, is extremely important. We're trying to prolong life, yes, but not at the expense of the quality of life. So, we look at what we call the performance status. So if you're in the 0 to 1 and 2, usually we're okay. But if you come and you're at 3 or 4, then that basically puts you in the category that you can no longer receive. You've exhausted some of these choices, that we can no longer perform these things because you don't have the hepatic reserve anymore. So the last thing I'll talk about is called image-guided ablation. It's a very different type of therapy. So when you are in the later ECOG 3, 4, sometimes we're able to use the ablation instead of the embolization, because basically what it does is it kills cells by using thermal energy, whether it's heating it or freezing it. So you cook it or you freeze it, right? So the same thing is, the same result is cell death. We want to accomplish cell death. And so and different types of energies are used, either radiofrequency, cryoablation, which is the freezing, or lately the microwave ablation has really taken off. And this is relatively new and really hasn't taken off yet because it doesn't have enough evidence to support that. In the old days, when I used to train, we didn't have the maturation of the technology for ablation, so we would just stick a needle into the tumor and inject alcohol in there. And the alcohol basically breaks down the cell. It's not as effective because it's a little bit uncontrolled. It kind of flows wherever it wants. But the energy is a more controlled way to perform the ablation. So it consists of a needle and a machine, the generator, that generates whatever the energy of choice might be, okay? So usually we perform this in a CT or ultrasound-guided environment. We put you into the CT scan, we scan you, we identify the area that we need to ablate, we guide the needle into that lesion under CT guidance, and then we use either the electromagnetic or radio frequency waves to actually deliver the heat. And it cooks like an area, basically causes cell death by thermal energy. And if you have a tumor of that size, the idea is to create an energy sphere or zone that is bigger than it, so you have a margin, right? Just like surgery. If you're gonna go in and cut it out, you're not gonna just cut the tumor itself, you're gonna cut a slightly bigger area, so you ensure that you cover the entire margin. It's the same principle with the heat. So you put the probe in there, and the heat is generated from the tip, and you create a little sphere, or actually elliptical shape, and you encompass the entire tumor. And in this entire zone, the temperature is so high, the cells die, okay? So this is an example of that. This is a CT image. We guide the needle into the area that we want to ablate, and then we cook it. And usually the time is not very long. With microwave, 5 minutes. And you're already achieving a temperature greater than 70, 80, sometimes 100 degrees. And that will cause kind of like a zone of death in that area. And so again, that's the energy. We want to make sure that we calculate the geometry of the tumor. And sometimes it's kind of big. So maximum diameter typically for one probe is about, optimally less than 4. If you're greater than 4, your technical success rate goes down from the high 90s into the 80s, right? So if you have something big, then what do? So what we do is we put 2 or 3 or 4 probes in a stagger fashion. So you create, just like if you remember geometry, if you stagger them, multiple spheres, then you end up with a larger sphere. And so that's how we can perform some of these larger lesions, okay? But it's not optimal. So now what we do sometimes is on the larger ones, we would do a chase first, and then we come back and we ablate it again. So we killed it again to ensure that we're getting cell death in that entire area. So ablation, basically, we have to make sure that the lesions can be safely targeted. Sometimes they're way too deep or they're next to a vessel, then we're unable to get there safely. And that, in that instance, we're unable to do ablation. We have to rely on the embolization, the chase or the radioembolization. If it's really, really big, we might not be able to do that. The ablation times can be very short, so it's well tolerated. A lot of times we can just do them under sedation. We don't even have to put you under anesthesia, okay? It's an outpatient procedure. You often leave the same day. We do this in a lot of organs, in the lung, in the liver, in the kidneys. We've done it in the chest wall. I've done it in the spine. We've seen them done in breasts nowadays, and also even in the head and neck area, okay? So as long as you can target that tumor with imaging and with that needle, you're able to cook it and kill it. And then what we do is we follow up with CT or MRI, every so often, in the same fashion that we do with the embolization techniques. Okay, so last slide. So it's busy, but I want to kind of give you an idea as to how do we triage these, patients when they come to us. And if you're, early stage, you can resect. They go to surgery and they get it resected. If you're not resectable, multiple nodules or they're bigger, then we often, if we can target them by ablation, we'll do so. And we try to downstage it sometimes so we can get to liver transplantation or resectability, right? So they can actually, if they cannot resect now, maybe they can resect after we treat them. And that is one of the kind of the goals of these therapies nowadays, is to work together with the surgeon so we can try to see if we can downstage it to the extent that you can actually resect it afterwards. And if not, you're intermediate, and you're multiple nodules, both lobes, then you're going to the embolization techniques that we talked about, and in conjunction with Nexivar sorafenib together. And beyond that, then if the the prognosis is really poor, then we're beyond, some of these options that we may be able to offer, okay? So if you have any questions about any of these, I encourage you to go to this website. The Society of Interventional Radiology has a patient portal that provides a lot of information on these things. You can get more information that way. All right. Thank you for your attention.